Most of the dental procedures that we perform in the dental office begin with an administration of local anesthesia on the patient. This anesthesia enables us to perform any kind of dental treatment without pain sensation. Local anesthetics have evolved a lot lately, and as a result, we now have local anesthetics with a great analgesic effect that make dental treatments easier. To administrate anesthesia, we need specific instruments. Local anesthetics packaged as carpules, dental needles, and specific syringes. The carpule syringe has two parts. First, we set the carpule. And then we assemble the needle. There are different diameters and lengths of needles for local anesthesia, depending on the anesthesia technique, infiltrative or block technique. The needle has a part that penetrates into the carpule diaphragm, a cone that is screwed to the syringe, and a reed that ends in a bevel. The cone has a little dot that shows where the bevel is. Now we are going to use a cheek retractor, specifically a Minnesota retractor. This is a benzocaine gel. We are going to apply it on the area where we are going to make the puncture to minimize the pain. To perform a tooth extraction, anesthesia has to be total. Add gingiva, dental pulp, because it is an aggressive procedure. We are going to perform an infiltrative anesthesia in this particular case. We do not need an absolute anesthesia because the tooth is already periodontally compromised. To perform this infiltrative anesthesia, we tense the lip and the vestibule to enable the needle to penetrate easily and gently. We need to localize the tooth apex area. Then we tense the lip and vestibule and we start the anesthetic infiltration. A light aspiration should be done to check if we have penetrated a blood vessel. If not, we can infiltrate the local anesthetic slowly. As we are infiltrating the anesthetic, we can see that a fovea is being formed. The reason is because it is formed by the liquid that is penetrated into the soft tissue. We can do a light massage to disperse the anesthetic. The needle does not have to penetrate entirely into the soft tissue. It is essential that 2/3 of the needle be out of the soft tissue. We infiltrate a little bit on the lingual side. Now we need to wait a few seconds because the anesthetic is starting to have its effect. It is fast. The patient feels pressure when we are infiltrating the anesthetic. Sometimes the patient is confused and thinks he can feel pain. But actually what he feels is just pressure when the liquid comes into the soft tissue. As a general rule, to anesthetize the mandible, it is desirable to perform a block of the inferior alveolar nerve. To do this, we usually use a 2,7G needle, which is a longer needle of 35 millimeters and stiffer. We use this blocking technique in the mandible because the infiltrative technique has limitations to reach the apex due to the thickness of the mandibular cortical plate. For a mandibular nerve block, the needle is assembled as the infiltrative one. They have a double or triple bevel. They're made of steel and have different diameters. They are acid-etched and silicone-coated to penetrate into the soft tissue more easily. The bevel is very sharp-pointed, and when it reaches the bone, it usually blunts. Because of this, we should remember that to perform several punctures with the same needle can produce micro-tears in the soft tissue, and the patient can feel pain due to this. We try to infiltrate the anesthetic into the Spix's spine, which is located on the inner or medial surface of the ascending ramus, where the inferior alveolar nerve penetrates into the mandible. To do so, we have to place the syringe at the contralateral side, generally located between the premolars, and then to direct the needle towards the inner surface of the opposite side. To be accurate, we have to check manually where the anterior edge of the ramus is. I'm touching it now. And the Spix's spine is more or less located at the level of the occlusal surface of molars. This would be the point of puncture. Now that we have made the puncture, we can inject the anesthetic. We have to reach the bone, retract a little bit, and before injecting, we have to aspirate in order to avoid a local anesthetic infiltration into a blood vessel. After the puncture, we have to cover the needle with the cap to avoid accidents. It is very important to do it correctly, because the risk of self-damaging is high. We should do it with caution and with all our senses on the action.